everyone, and welcome to our webinar, which is going to focus on our brand new person-centered health and social care programme starting in September 2019. We're joined today by Michael Laughlin and Andrew Miles, who are professors here at the University of West London. They're both lecturers at the university and will be teaching on this course. We will be kicking off the discussion shortly, but first I'm just going to provide you with a quick overview of the University of West London. For those of you that aren't familiar with it, I hope that this will be useful for you. In terms of the way that the webinar is going to be structured, as I just said, there'll be a welcome to the university. We're then going to kick off with the discussion. So I hope that you will find that useful. If you have any questions or you have any points that you would like to make throughout the webinar, please ask the questions in the chat function. You should see that there's a chat box towards the bottom of the screen. Please do that. We will see that you've asked a question or that you're making a statement, and that way we can include you within the discussion. After that, there'll be some slides on the course structure, the modules that are offered, the study mode as well. So hopefully that will, if the questions haven't been answered during this discussion, that will provide some clarity for you. And there's also going to be further time at the end for any questions that you have. Okay, so in terms of the oops, sorry, I've just gone ahead with the slide then. The location of the University of West London. We have two sites in West London. We have our Brentford site and our Ealing site. We also have a campus in Reading for our College of Nursing, Midwifery and Healthcare. Both of our campuses have very easy access to central London. They're both around about a 30-minute journey from central London. Our Ealing campus is connected by both the Central line, the District line and the Piccadilly line. Our Brentford site is connected by rail and it's around about a 15 to 20-minute journey to Waterloo Station from there. You'll see on the map that we are also surrounded by a lot of lovely parks. So we have Gunnersbury Park, Boston Manor Park, the Royal Botanic Gardens, Walpole Park, Lammas Park. Our Brentford site is surrounded by West Middlesex Hospital. And you'll also see on there, actually close to our Ealing site, we have Ealing Studio. So if you're particularly interested in film, then that will be of interest to you. You can see on the map as well, our journey time into Heathrow Airport is around about 20 minutes. So we're really well connected transport-wise to both the airport and central London. Here on the screen, you'll see some of the key facts, some facts that we're really proud of here at the University of West London, and just some of them really showing that the university is really on the rise. So 98% of our graduates are in employment or further studies 6 months after graduating. At the university, our courses, we want to make sure that you're ready and prepared to go into the career that you want to do. So along with the course content, we also have an amazing careers service here at the university who you can go and see. They do drop-in sessions and really help you out in terms of going on to that next step. We've climbed 46 places in the Guardian University Guide over the past 2 years, and we're ranked as the 50th university nationally by the Guardian University Guide 2019. Our consistently high standard of teaching was recognised with a Silver Award in the Teaching Excellence Framework, and we're ranked top in London for teaching quality and student experience by the Times and Sunday Times Good University Guide in 2018. In terms of facilities, we've recently had over £150 million invested in new equipment and resources. So if you come along and visit the campus, you'll see that a lot of our facilities are very new and state of the art. So we have a 24-hour library here at the university. We have transformed teaching spaces. We have simulation centres for our nursing, midwifery, healthcare professionals. We've also got something called the Savoy Suite, which is a dedicated area for postgraduate students at our Ealing Broadway site. It has a 50-seat lecture theatre and a multifunctional area that can be converted into a large space suitable for group workshops. Also last year, the final point on here is that we were shortlisted for the Times Higher University of the Year award last year. So if at the end of this webinar you decide that you would like to apply for the programme, which we hope is the case, but here's some information about how you do that. So all of our applications to our master's programmes are made by the University of West London website. When you search for the course on the website, you'll see in the sort of right hand corner there's a green apply now button. You need to click on that and that will guide you through the process. Once you've done that, you'll be asked to provide details of the qualifications you have obtained, details of any relevant work experience that you've undertaken, whether or not that's paid or unpaid, the contact details of an academic or professional referee, and you'll also be asked to submit a personal statement detailing your suitability for the programme, any experience that you have that you think that our admissions team and our academics here at the university will want to hear about, to ensure that you're a suitable candidate. There's also a lot of ways that you can visit us. So we run twice weekly campus tours. We run these on Tuesdays at 11 o'clock and Thursdays at 2 o'clock. We also run once a month campus tour late. So if you're unable to make any of the daytime sessions, then please have a look on our website for dates of our campus tour lates, which run from 6 o'clock to 7 o'clock. All of our campus tours are run by our student ambassadors. They're a really great opportunity to get to know more about the university from a student perspective, and hear about the facilities that they use. We also have postgraduate open evenings. So our next one is on Thursday, the 20th of June from 4 o'clock to 7 o'clock. So if after this webinar you wanted to come and have a look at the facilities and have a chat one-to-one with the academics, then that's a great opportunity to do that. So please have a look on the website and you can book onto those on there. Okay, so now what we would like to do is launch a poll. So the nature of this webinar is we want it to be a discussion. We want you to be involved and we want you to find out more about the course in this way. So you should see a poll coming up. So please select your answers. So are current health services sufficiently person-centred? I'll just give you around about 10 seconds to answer. Okay, so thank you to those of you who voted. I'll just wait a little bit longer and then I will release the results. Okay, so share results. Okay, here we go. So that's quite a clear-cut result there. So you should be able to see those on the screen. So are current health services sufficiently person-centred? 100% of our attendees have said no. So Michael and Andrew, I'm going to pass this over to you. Is there anything you'd like to say about that? What would you like to say?
Michael speaking. So yeah, it's not entirely surprising, I guess. I mean, no isn't a terribly controversial answer either, because it's not as if we're anyone's being too critical here, given that the NHS documents themselves are all about how we desperately need to become more person-centred and how on earth are we going to do it, and all these proposals, all various health and social policy documents that are all saying the same thing and talking about the need to integrate health and social care. You know, we have councils that have specifically declared that a major policy and they're trying to spend money on doing it and how you do it. But of course there are all sorts of issues that need to be confronted. So it's like people are broadly agreed on that no answer from, you know, even senior policymakers. But then part of the problem is, of course, practitioners are trained, you know, and need to do well by being specialists and looking at their own specific function. And then at some point, people are now being told there is a need to move to a new model of care where you've got to be generalists. And, you know, and the whole way that services are organised and structured is in this sort of specialist divide. You know, you've got healthcare over here, social care over there. Yep. And now they're being told, hey guys, you've got to integrate. And it's surprising that there's inadequate research on how this is going to be accomplished and what it's going to mean for people in practice. And astonishingly, you know, this will be the first actual devoted course to this in England and Wales. Yes, so what we need to do, I think there's a broad agreement that no is the answer there. And then the question is, what do we do about it?
Yes, I mean, I again, likewise, I'm not surprised at the result. I think, I mean, modern health services, the NHS particularly, is focused, I mean, overwhelmingly on productivity, pushing as many patients through the system as quickly as possible, really, and that's the issue we've got. It's an NHS focused on productivity rather than on, if you like, clinical quality per se. And that's the same whether you're talking about a hospital or whether you're talking about a GP surgery. There's this focus on service efficiency. pushing as many people through as possible, keeping those waiting times as low as possible to meet political targets, and of course, if you look also, of course, there's a focus entirely on the biological body within health services, really, rather than on the whole person. So it's really a focus on the disease rather than the person, the disease, almost as if the disease has the person attached, rather than, focus on the person who has the disease and is actually living with the multiple sequelae of that disease. So I think this focus on this relentless focus on the biological body and the relentless focus on productivity, pushing as many people through the system as possible. Yeah, I think that equals no, really, to that question.
Okay, so I mean, clearly one of the issues then is, well, okay, reasonably, what do we do about this? And we have to be, we have to be careful in what we're saying and what we're not saying. So one of the things we're trying to do, as well as organising this particular master's course, we're also, Andrew and I are both editors. We both, Andrew edits a journal, which is about person-centred care. I'm editing a volume, which is going to be on the sort of the latest thinking in person-centred care, trying to develop this area. Now, one of the issues is, well, what precisely are we doing and what are we not trying to do with this? And one of the things that there's a debate that's ongoing, there's some interesting contributions to it, but one of the things we hope to do with this degree is allow students to kind of develop their own thinking and their own conceptions as to what person-centred care means for their practices, because this is an ongoing debate. And one of the great things I found in teaching other sort of professionals and practitioners in other areas is, to some extent, when you do critical thinking, I mean, I used to use this phrase, was it training in intellectual and moral self-defense? You want to, it helps you develop your own ideas. Not you might well want to question some of your own assumptions, but equally, you might, it's nice. Some practitioners go away saying, yes, I feel that, I was able to defend my corner better having attended your course.
Yeah, sure.
I have certain intuitions and certain things that I just thought were right and certain things that seemed to me wrong. And now I've got a better sense of why, and they can make connections with what the broader arguments are, and they can see that they weren't that misguided in the first place.
Sure, exactly.
And so it's one of the great things about being able to do a course like this is just getting people together from different backgrounds and helping them to sort of share their own ideas and their own assumptions, and critique them, not necessarily, perhaps to change your view sometimes, but not necessarily to change your view. Sometimes to learn how to give it the defense it needs in your context, so you can move forward with more confidence in bringing about the kind of changes that you want to achieve.
Sure. Yeah.
Okay, so thank you, Michael and Andrew, for that. So as you just mentioned, this is something in terms of people thinking about what person-centred means to them. That was something that person-centred health means to them. That will be covered in the course. What do you think person-centred health and social care means?
Well, I mean, basically, I mean, it's in the name, so to speak. Person-centered care is care focused on the person, which means care that is focused on the whole person, not just the disease. So you're talking about, of course, one has to focus on the disease and use all of the reliable science, and we must remember, of course, that only a small amount of the science we have in healthcare is actually reliable. That's becoming quite obvious. But we need, for good clinical care, we need, and for person-centered care, really, it's science alone is necessary but insufficient. We need science plus. And what is the plus? Well, the plus is humanism, really. We need science and humanism. We certainly don't want a science-only based care. That would be a very poor, that would be a great poverty. And we certainly don't want a humanities-only care, because that might end up killing you, quite frankly. So, but we need the two brought from, not seen as polar opposites, but brought into a sort of close and functional integration, really. Together. So yes, of course, we attend to the disease, but the disease itself results in a range of sequelae. It's not just the tumor in the liver or the rash on the foot and so on. What you find is that the disease radiates outwards and produces all sorts of effects. The disease creates effects which go beyond the physical symptoms. So I think, good clinical care, and this is difficult when you have only a limited amount of time to see patients, of course, but We need to be concerned with the patient's story of illness, the lived experience of illness, the so-called phenomenology of the patient. So we need to know about the patient's narrative. The patient will have values. The patient will have preferences, which are very important in terms of coming to a decision with the clinician about which therapeutic options, or none, to elect for. We need to be concerned also with the patient's emotions, and existential worries, the patient's psychology, of course, spiritual and factors. We need to be culturally sensitive in the way we deal with the patient. We have to take into account the patient's life plans, the patient's worries, fears, anxieties, goals, the effect of the disease on the patient's work, and therefore economic factors, and a lot more, really. So really, yes, where it is really about focus not on the patient as a statistical unit in the health service with a particular disease or diseases. It's a function on the whole person, that unique individual in front of you, who will have a range of concerns, which are a function of the multiple sequelae that the underlying pathology or pathologies are causing.
Okay, thank you. Michael, is there anything that you would like to add in terms of what you think person-centered health means?
Well, yes. Well, I mean, I think, you know, I'm broadly in agreement with what Andrew has said there. I mean, obviously, the point is we don't want to, you know, we're not. There's a lot of work now on the limitations to what's sometimes called the biomedical model. A lot of sort of the authors. What we're trying to do, because I'm putting this volume together, and it's got some of the sort of key contributors globally to the debate about personal care and how we move it forward in the future. And we're hoping to be able to bring some of these people in to either to take part in, to contribute to sessions and teach session degree, or to organise a set of lecture series where we can invite our students to attend these things, and so they're really up to date with the ongoing debate about it. And you know, one of the issues is going to be, you know, to be clear on what person-centred care, what we mean by it, what it is and isn't, and we're not, you know, while people, you know, there is this criticism of the biomedical model, as Andrew indicated, clearly. This isn't, it's about its limitations, and now there's nothing wrong with it being limited as long as we recognise that. I mean, part of the reason why we have some of the problems we have that have given rise to the, you know, so there's even policymakers are seeing the urgency of moving to person-centred care. Yeah. Part of the reason for that is because of the rise of, you know, chronic conditions, multimorbidity, aging populations. And of course, one of the reasons why we have these problems is because the biomedical model has to some extent been a victim of its own success. Because along with equally important, if not more important, social changes that people live in better conditions and so forth, but those changes and the progress that biomedicine has given us and the so-called curative impulse, what that has given us is a situation where there are lots of people who are alive now, who in previous centuries would definitely be dead. Oh yeah. And because of that, we now have to think about caring for conditions that are not going to be cured. We now have to tame the curative impulse. It's done a heck of a lot of good. Yeah. But now we need to think about ways of helping people live as the sort of people they are with the conditions they have.
Yeah, I mean, you mentioned limitations. I mean, you know, science is limited. There is a danger. It's a dangerous delusion that science can answer all of the necessary questions in medicine. You know, there's a real danger that we have an over reliance on science, so to speak. And I think that's something we have to guard against, and you know, and also I think we have to guard against a mentality in the health service, defensive medicine, defensive practices, which is sort of happy with care so long as it is technically competent and legally acceptable. That to me is that's a very almost cynical position, really. You know, as long as it's technically competent and legally acceptable, then you know, we've got our backs covered. It's okay. We don't really need to do more. Well, I'm afraid yes, you do need to do more, because that's a lower denominator, so to speak. We need a higher numerator, which is not being content with that basic level. You know, second rate is fine for second raters. Third rate is fine for third raters. That is not what an authentic professionalism is all about. We have to strive for excellence. That is the mark of an authentic professionalism, not a second rate, legally acceptable, technically competent thing. And that is, again, the essence, or the soul, if you like, of person-centered care, to strive for excellence. And treating the patient as a person is a form of excellence in clinical care. And I think we have to recognize that. And at last, published in January of this year, the NHS long-term plan, which looks forward to the next 5 years, puts a great deal of emphasis on the need to become more person-centered in health services. Unfortunately, like many NHS plans, it doesn't tell us how to do that. It's rich on aspirations and very poor on methodology. So, but methodology, how to do it, as well as, you know, if person-centered care is a way of thinking and doing in practice, if we will be teaching in this course you how to become more person-centered, but actually how to do it, not just how to think in a more person-centered way, but actually how to do it in hands-on practice when you are immediately opposite, looking into the eyes of the patient.
Yes.
Okay, thank you very much. So, Andrew, we're just going to move on to a statement from an article which you co-authored, actually. So in an article in the International Journal of Person-Centered Medicine, which was co-authored by yourself and Juan Mezic, it stated that person-centered medicine risks the accusation that such a term represents a further rhetorical addition to the already rhetorically overburdened nature of health services. This was in an article titled "The Care of the Patient and the Soul of the Clinic, Person-Centered Medicine as an Emergent Model of Modern Clinical Practice." Can you just tell us what was the basis for that accusation and how do we respond to it?
Well, should I say publish and be damned? That journal is in a sense a secondary journal. The principal journal in the field is the European Journal for Person-Centered Healthcare. But the publish and be damned, yes. I definitely think that's one for the professor of applied philosophy here, Michael.
Well, no, he actually, no, to be fair, he commissioned a new. You had about 400 responses to that article, didn't you, from myself?
Oh, huge.
And it really did expand the debate. I mean, part of the problem with the job, well, person-centered care. I mean, you notice in your poll you got 100%. It's not sufficiently person-centered. Had you said person-centered, is it a good thing or not? You would almost certainly have got 100% people saying yes, it's a good thing. Now, obviously, there's a history of that. Similarly, if you asked, should practice be evidence-based or not? Yes. You would guess 100% yes. Yeah. Now, part of the problem is terms like this, we have to be careful with. They have a certain rhetorical capacity. We need to be aware of that. There is, of course, a danger that they can become buzzwords and then they can start to mean all things to all people. And then the trouble is then the capacity for the language of person-centered care, like the capacity for language of evidence-based practice, to actually challenge and change practices then is then significantly diminished because you can start to present all manner of different things as being appropriately evidence-based or as appropriately person-centered. Now, the solution to that isn't necessarily to have have a little book where you've got one correct definition of what the terms mean, but rather what you need to have is a critical population, both critical, populations, both of ideally populations of workers, practitioners, and service users who are going to challenge the uses of these terms as they're made, and are not just going to accept anything as meaning person-centered. They say, no, this is what my perspective on this is, and practitioners do actually have strong views on what it means to be person-centered and what is appropriate evidence in a given context and so forth. And the important point is to get people discussing these issues critically and developing senses of the terms that they can use in practice and that are defensible, and also to understand when other people use them differently, why they do so. Not necessarily to change your view and change your usage, but we need to understand each other where we have differences. And one of the things, some of the research I've done, we've asked groups of practitioners to respond to certain fictionalized scenarios and to say, would you, for instance, Elsie has requested the following in this situation, would you do it, right? And you have to say what your underlying values are, and guess what? They all want to be person-centered, they all want to base their views on evidence, they all want to respect Elsie's autonomy, but they give different answers as to what they would do. Some some do what she asks and some don't, because they have all sorts of other views about, well, yeah, but that wasn't really an authentic request from Elsie, because the way the case is set up, it's clear that that's a bit out of character for her. So some people will think that doing what, respecting Elsie as a person means not doing what she says in this situation, and others will think it does. And then you have to say, well, okay, so now we need to have a debate amongst the participants as to why they think that. And whatever we do, our ideas are always framed by underlying assumptions, and it's sometimes good to be able to get to those assumptions, get them out and look at them, and just decide whether or not we want to modify them. And that way we can have an intelligent debate which actually makes it possible to improve the services. It's having that kind of critical activity that makes sense, that people are aware, not critical in a sort of a crude sense of always wanting to criticize whatever's being said anyway, but critical in the sensible sense, which includes being self-critical, where you have to think about your assumptions. Say, why are we doing this? Because we're not that sure. We are at a point in history. You know, it's like biomedicine has been amazing, and biomedical reductionism has brought amazing progress. But the point Andrew, I think, was making earlier is to have further progress. We are now at a point in history where we need to expand our conception of what good practice is.
Yes, I mean, you mentioned evidence and the matter of definition. When the problem really with evidence-based medicine, one of the principal problems. Of course, we need. Of course, practice must be informed with evidence. But with evidence-based medicine, evidence for them really meant scientific evidence, and not all questions of relevance to the care of patients are scientific in their nature, and therefore can't be answered by science. Some of the things I mentioned earlier about the patient's values and preferences and narratives and social situation, cultural situation, the patient's worries, fears, anxieties, goals, and so on. These are all sources of knowledge, epistemologically, as it were. So when we talk about evidence-based practice, well, first of all, should practice be based on scientific evidence? I would say absolutely not. Should it be informed by scientific evidence? Absolutely yes, but not just scientific evidence. So when we talk about evidence-based practice, I prefer knowledge-based practice. So when I talk about person-centered care and concepts of evidence, I prefer to talk about knowledge, because the word evidence now is so polluted and so misunderstood. I prefer to talk personally about clinical knowledge. What is the knowledge base, for example, for person-centered care? Why should we do it? And at some point, perhaps we can talk about that, because there's a growing empirical research base which shows that there are demonstrates empirically that there are major benefits to person-centered care. It's not just an ideal, something nice to do, something human to do. Of course, it's that, but actually, there's hard evidence to show major benefits as well.
Okay, thank you. So just then I've heard you both refer to both patients and people. So could you just sort of give a bit of an explanation as to whether or not there's a difference between patient-centered care and person-centered care?
Well, I mean, again, you've got to watch how the terminology is used, because there's some really important aspects of the patient-centered care movement that just gel totally with what we're trying to advocate in person-centered care. So the notion of patient empowerment, the notion of patient experts that's been achieved, the idea, to take people seriously, to have what we call in philosophy a phenomenological approach, to understand the experiences of service users and to treat them as extraordinarily important source of evidence. All of these things gel entirely with the patient-centered care movement, and there's movements such as relationship-centered care, which build in the crucial social aspects to someone's personhood. These are very important as well. Insofar as the distinction and why I tend to think person-centered is a better term, there's two reasons really. One is that person-centered brings in the notion of the agency.
Yes.
Patient, because really, and so we wrote a paper on this recently. The patient, the terminology of patient, if you look at its origins, is someone who is acted upon as opposed to someone who acts. Whereas an agency is another aspect. Persons are simultaneously agents and patients. We're constantly acting on others and being acted upon in different social contexts. And it's important to stress the agency of the patient, to understand the patient's lifestyle and how that affects their condition, their particular values that can make a difference as to what is the best outcome for them. We can't just assume that practice is about diagnosing a disease and then finding, using your evidence base to find out what is the best cure to use for, or the most statistically likely treatment to cure that condition, because the particular patient's values might differ from that. There's that wonderful example from one of our colleagues, Yelovich, an author, Mary Claire Yelovich. She gives this example about a particular patient who was a dancer, and she had a breathing disorder, and her clinician, wondered why she wasn't complying basically with the instructions that he clearly given her. And of course, it's because she had learned that the treatment he was given her, which was clinically, and if you looked at your research trials, the best treatment to cure her condition as quickly as possible, had effects on her mobility.
Yes.
And it had effects on her muscle control. And she said, look, the whole point for me of getting better is so I can dance.
Exactly.
I live to dance.
Yep, like plans, like goals.
This was my... And so in that case, you had to find a compromised treatment that did... Now, there are many cases of that where you have to focus on the agency of the patient, and you have to say that person's values actually have to be a fundamental piece of information.
Yes, yeah.
So one of the things about person-centered care is that it focuses on agency in this way. Another important feature is that it's not just about focusing on the patient. The person-centered care is about recognizing the personhood of the practitioner.
Yes, absolutely. This is often forgotten, isn't it? It's often sidelined, and it shouldn't be. It's as central, really, as the patient, because the two are in a position of relationship as people, a relationship of trust and closeness. So that's as important, really, in my view.
And in terms of what you call clinical epistemology and so forth, there's another wonderful author. I think I think he's also a Canadian author, Stephen Henry. I published some of his stuff a few years ago, but he has this wonderful statement. The clinical encounter is an interaction between persons.
Yes.
The point is, you've got to take into account your own personhood as a practitioner. And what Henry says as a practitioner himself was that when he tried to justify his decisions, he said there was almost kind of a dark secret that he was hiding, because he was using his human capacities. He was using his intuitions, his tacit knowledge, his sense of who this person was that he was dealing with to find the right decision. But when he wrote it up, he had to make out it was a proper technical scientific basis that he'd given for his decision. So he de-emphasized the fact, well, I didn't give that to Harry because I've known Harry long enough to know this. You don't say things like that because they're too anecdotal. And he was saying we need to have a language where we can use our human capacities and develop our wisdom.
Very important word. Wisdom, clinical wisdom, phronesis, as Aristotle would have had it.
Yes. So for that, and again, these are things which it's not as if clinical practice has forgotten these things over the years, or indeed health or social practice generally have totally forgotten over the years. They've just been sort of sidelined. They've always been there.
Yes.
And you can go back to ancient times and you will find discussions about this. But nonetheless, as I said, not necessarily for bad reasons, there's been a focus on specializing and on finding clinical solutions to certain problems that has achieved extraordinary progress.
Yes.
But now we need to move forward, and we need to reintroduce some of the things that we haven't exactly lost, but have sort of put to the side.
Oh, I agree. As someone once said, healthcare needs to remember all of those things that it's forgotten in over a century of empiricism. So it's like what is the word in Greek? Anamnesis, a sort of remembering. Healthcare needs to remember what it's sort of forgotten. Talking about patients and persons, I mean, there are some people who have an objection to using the word patient. I once talked to some diabetic people, and I said, as patients, how do you feel? And they really remonstrated with me, and they said, we're not patients. We are people living with diabetes. And I had this similar conversation with people with HIV, and they said, no, we're not HIV patients. We are people living with HIV. I personally have no objection to the word patient, although person is actually more, well, is comprehensive really, whereas patient in a sense is a reductionist term in a sense. Of course, we must remember that patient, it comes from the Latin patiens, which translates as he who suffers, he or she who suffers. And I think it's an eminently, whereas person is best, of course, but I think that patient is eminently better than client or customer or service user. I have a very good colleague whose name I mustn't mention, but Michael will know who it is, who once, very colourful and very not one to mince words, who once said, clients, customers, service users, what utter nonsense. Only lawyers and prostitutes have clients, doctors have patients. And, and you can imagine that is seared on my memory forever, and now on all of yours, no doubt.
Well, let's not put that under course publicity. There's some issues with that.
It makes the point vividly. I think it could be said.
Okay, thank you very much, Andrew and Michael. I think you've raised some really interesting issues there, and I think through the discussion you've sort of highlighted what this course means and what people will be addressing and focusing in this. Clearly, there's a lot of critical analysis involved in this course. I'd just like to sort of go through the some of the modules that you will study, while some of that's been covered in the discussion. I think it would be nice for attendees to just see what those are on the screen. So if I can just get those up, and if you could just sort of provide a bit of an overview as to, there we go, some of these modules. So we've got your compulsory modules there and the optional modules. So if you could just give a bit of information about those.
Okay, so we've got your theory and practice of person-centered health and social care. And it's important to emphasise, the importance of social care as well. We don't want to treat that as a side issue. The whole point is that we are needing to revise our conception of health so that social aspects are part and parcel of it, and that what people are doing in areas like social work is absolutely essential.
Yes.
To people. And in some cases, I say social changes have been an even greater contribution to improvements in general health than even some of the best results of medicine. So really, this is the sort of first sort of introductory module. It's the biggest module, and all the modules are going to be delivered via these weekend workshops. So what we have is you have online support, and people will get sort of exercise and information in advance, and there will be people they can contact. And then we have these intensive sessions, these weekend workshops. So we have a couple of them for the first module. We'll have one for each of the other modules going throughout the year. Now, and then you get the chance to, we have further sessions. We have online sessions where students can meet each other online and discuss issues, and there's, and they can relate. They can speak to the tutor accessibility. Really, the content of this first module is to give this background. Some of the issues we've been talking about, complexity, multimorbidity, lifestyle, the relationship between the biomedical model and movements towards what's often called more humanistic models, relationship between science and culture and society, and some of these issues about the distinctions that we've just talked about: patient-centered, person-centered care, the criticism of both types, that they can be consumerist in nature, and the claim that that is problematic in one way or another, and responses to that. Issues about personhood, agency, responsibility, but really focusing on how people can use these concepts to make sense of their own practice. And so when we look at things like the assignments that we set, they're going to be focused on, enabling people to negotiate. So to give, for instance, for this module, a presentation where they will be asked to apply some of the materials and some of the methodologies they've learned about to a case or issue that is relevant to their practice or their experience. And then we also have a reflective account of an intervention or a practice-based problem, which is a written component to it. And the idea is it's going to be helping people think about what is distinctive to a person-centered approach and what isn't.
Yeah, sure.
And what's the difference between the two. And it's important to do this, and also in a way that avoids caricature.
Yeah.
Because if you caricature, then the danger is that person-centeredness becomes, as I say, it just becomes a buzzword then.
Yeah, sure.
And anything which is, you want to show why there are credible, intelligent people who, as far as we can tell right now, are not practicing in a person-centered way.
Exactly.
And what are the issues that lead to that? No. So you don't want, so they will be getting that level of sort of nuance to it. Now with health and well-being, we'll go into more detail on some of the, what I think are quite important underlying questions about the nature of health. This has been an ongoing debate for a long time. So biomedical accounts sometimes refer to something called the biostatistical account of health. Well, this has got certain strengths, it's also got certain limitations. There's been lengthy and ongoing debate about this. There are conceptions of health, the famous World Health Organization, which is often seen as a very humanistic and to some extent idealistic idea of this sort of complete sense of personal well-being that defines health with reference to the notion of well-being. There are other accounts to do with helping people achieve their goals, the notion of autonomy, holism, and they do reflect. It's important in each case to look at practical cases, because as I said, we can sometimes say we espouse the same values, and yet we will do different things in particular cases. We can both think we're respecting the autonomy of the patient, but come up with two different proposals as to what you should do to respect that autonomy. And that's it. When you've got all the empirical information, when you said to Gladys, what would you like us to do at that point, Gladys? And she's given you an answer, you will still get practitioners giving different answers as to what they should do. And so it's about thinking those things through and being able to justify yourself or think through what your answer is in terms of, what conception of health and well-being and care makes sense. What's the relationship between things like science, value, health as a social concept, well-being, self-determination? What's the relationships between these things? And these are kind of good things that citizens of a free society should be thinking about anyway.
Exactly.
And certainly if we're going to be talking about caring for our fellow human beings, these are good things for people to be thinking about. And so we have assignments based on that. Now there's other modules. I mean, I don't talk about there's implementation and change. Now obviously it's a long-winded title, but we were advised to incorporate all the different components, everything that you get to learn about in this module, sort of in the title. So it's leadership, implementation, change, leadership, and shared decision making. It's a long title, but basically, as people will be aware, there's a massive emphasis now on shared decision making, but lots of different theories as to what exactly it means. And there's we had
and legal requirements now, of course.
Well, of course, with the Montgomery verdict and so forth, there's still debates over that and what on earth people are supposed to do about it. But the idea is that shared decision making has to mean something that until not long ago, a lot of people didn't think it meant.
Yeah.
And so how we actually incorporate that into our practices is a big question that's confronting both managers, policymakers, and practitioners at the front of practice. So there are big questions there. There are all sorts of questions about health and social policy, the relationship between guidelines and personal judgment, what we mean by wisdom in these situations, and can we aspire to that? That's what we would ideally, to be proper professionals. We would want to be learning to make wise decisions, and questions about measures and health measures and quality measures and so forth. And we're constantly, in practice, we're constantly bombarded with all sorts of figures and statistics. And it's sometimes useful to be able to have a kind of, to take a critical line and say, hang on, but what exactly does that mean? Ask some difficult questions. And you'll sometimes find that the people who are giving you the instructions aren't sure themselves as to what the answers to the questions are.
Exactly.
So these are useful skills to have, and then to think about how you employ them in particular contexts is going to be a further issue. Sometimes it's not always wise to, in every context, to ask critical questions. But
no, quite. One has to be pragmatic. One has to have wisdom in these things.
Yes. So there are these issues about. One of the big issues about. So priority setting or rationing, and there's been a debate I've been involved with about practitioners wanting to defend their corner in that and their particular perspectives on that issue. And so there are all sorts of ongoing discussions, which is just very nice to be aware of. Now, the other compulsory module is the research methods. Now, again, obviously, you're preparing there, you're looking at what it means to research in a way that is person-centered, different research strategies. I don't know if Andrew wants to make any comments on this, but we basically, we're moving there. One of the things you're doing there is putting together a proposal for your dissertation, because we want you to be able to do a dissertation that is actually going to be helpful and interesting. So you want to negotiate a topic that makes sense to you, and we want to connect you to a supervisor who has the proper experience and sense to be able to supervise that. And you're working towards that with your research methods and thinking, what's the best methodology for the precise questions that I want to answer? Yeah,
so with traditionally in person-centered care and patient-centered care, person-centered care, qualitative research has been the bedrock. It's been the principal tool of investigation. But in latter years, certainly over the last decade or more, we've seen a growing number of qualitative, empirical, so-called hard approaches to person-centered care, and many of these have generated the current evidence base for person-centered care. You know, that person-centered approaches increase patients' adherence to complex and simple medication regimens, that when they do that, their exacerbations of illness go down, the hospital admission rates go down, length of stay goes down, patient satisfaction goes up, burnout rates go down, et cetera, et cetera, et cetera. So a lot of those studies. So in that module, we'll be teaching not only, you know, the solid, good qualitative research, but a range of quantitative research methods as well. So there'll be a very solid, broad grounding in how you investigate and develop person-centered care there.
Okay, and of course there's also the optional modules. Now we've got person-centered mental health care, and obviously for some people this will be more appropriate than others. There's a lot of really interesting discussion going on there. Some of the points I was making there about respecting people's decisions, for instance, they are focused very well by some of the debates about different types of mental health conditions and, you know, types of personality disorder. There's a big debate going on now about the notion of epistemic injustice, and it's particularly important in the area of mental health, where, you know, the idea that, you know, because of the type of conditions you have or have been diagnosed with, your ideas, your accounts of your own experience are not taken seriously and are not taken as proper evidence in the way they would be if others gave accounts of their experiences. And there are questions to what one does about that, but and to how, you know, how one overcomes what's seen to be biases. Although, of course, you know, it's a controversial issue. There are times when I wouldn't want people to take what I say totally seriously, you know, and there's all these issues about, you know, what it is to have an authentic self, and things like self-binding directives have become a big issue with this for certain of our colleagues, where, you know, you have this person basically has told you previously that if I'm in this condition later on, don't take what I say seriously. Now they are demanding you do certain things, and, you know, and again, there are really important issues here. There's also issues about, I want to cover in that module, about things like, you know, questions. There's this big old-fashioned, it's a debate going for a very long time about psychiatric diagnosis and the validity of different categories and the relationship between scientific and value judgments in them. And at one point it was considered a sort of terrible secret that value judgments might be involved in different types of psychiatric diagnosis, and that social judgments might be involved. Whereas now I think people accept that is the case. It doesn't necessarily mean you write off all conceptions of mental illness as somehow not appropriate. You have to say, okay, how do we explain, understand, and justify our values, and how do we debate them, especially when we have differences? And so this is, you know, so there's all sorts of issues that module will cover. So I don't know, do you want to say anything about the primary care and the secondary care?
Yes, I'm conscious about people's listeners' time, but I mean, very briefly, the primary care module it really is all about something Michael mentioned at the very beginning of the webinar, or touched upon at the very beginning of the webinar, chronic illness, long-term chronic clinically and socially complex illness. So we're talking about, you know, diabetes, cardiovascular disease, respiratory diseases, the cancers, mental health care, all sorts of other chronic, say, neurological illnesses, the Parkinson's, motor neuron disease, multiple sclerosis, et cetera, et cetera, et cetera. And there is a rapidly growing evidence base now, or scientific evidence base, I should say, to qualify my terms, which shows that person-centered approaches to the care of these conditions result in absolutely measurably greater, better clinical outcomes. That's no longer a debate. I mean, that's been documented. So person-centered care is central to the care of these conditions. So that particular module will focus on the management of chronic illness in primary care, and the primary care secondary care interface where that is. And I mean, again, very briefly, the secondary care module will have 4 areas of focus. Palliative care, care of the elderly, pediatrics, so-called family and child-centered care, and acute psychiatry. as well, which will draw to an extent on that other module and put that in the context of acute psychiatry. So palliative care, elderly care of the elderly, pediatrics, and psychiatry in the secondary care. So those two modules will give a very detailed overview of how we use person-centered care in both the primary and secondary care and tertiary care settings.
Okay, brilliant. Thank you, Andrew and Michael. So I hope that's given you a bit more information about the modules that you'll study on the programme. Just going to now talk a bit about, sorry, and the screen is, there we go. Just in terms of the study mode, so the information is on the screen in terms of the duration. It's a part-time 2-year course, and it's run via a series of weekend workshops. Michael and Andrew, is there anything in terms of this that anything more you'd like to say? Or
well, I think we've already said about this. You know, the weekend workshops, the idea is they will be intensive sessions, and we'll have lots of, you know, we'll have. When
do they start? On a Friday, don't they? And
that's right. Starts on a Friday, run over, you know, Friday evening, run over, go throughout Saturday, and then sort of after lunch on Sunday, kind of thing.
Yeah. So importantly, there'll be a teaching. Importantly, there'll be a social element as well as all the teaching. Yes. But they're intensive, but they'll also be fun, quite frankly.
The idea is to get people together so that people can ask questions, have debates with each other, and a lot of these sessions, certainly with my own stuff. I mean, you know, I used to use this term in terms of delivery of interrupted exposition as the basic strategy that you kind of hope you will have a group of students who will come in and you're trying to get points across, and they're saying, "Hang on a minute. Why do you say that? What do you mean by that?" You know, and that they will come in and have their own position and their own ideas they want to bring in and debate, and that people will all learn from each other.
Yeah, exactly.
Them sitting there being taught stuff. We all have something to bring to it.
Absolutely.
Each other, and that process of discussion is what actually helps us to think more about what we mean by what we're doing.
Sure.
Okay, so just to go over the entry requirements here. So as you'll see on the screen, you must have an undergraduate degree or an equivalent professional qualification. And we particularly welcome your application if you're a qualified practitioner in a relevant field such as nursing, midwifery, medicine, social work or psychiatry, and you have extensive experience of primary or secondary healthcare settings. Again, is there anything, Michael and Andrew, that you would like to say on that?
Well, it's you know, there are clear criteria there, but what we want to do is we want to make sure that, you know, we're interested to hear your application. We will listen to whatever what your reasons are. The main thing is we're looking for capacity, what you used to call capacity to benefit. You know, the reason why you let someone join the degree was because you shared their view. They wanted to apply for it. You shared their view. It was in their interest to do it. Yeah. And if a particular applicant can convince us of that, then we're very interested to hear.
And if you do have any very specific questions about qualifications or the entry requirements, then you can email our admissions team. Their email address is postgraduate.admissions@uwl.ac.uk. Okay, so that's the end of the webinar. I just want to see, I can see we've got one question here from Antonia. So Antonia has asked, when can I apply? Applications to the course are open now.
Yes.
So
you can apply as soon as you like. You put in the application and we will assess it as quickly as we can. Obviously, the admissions department has its standard process and criteria that you go through, but you know they're fairly transparent, and we'll be very happy to receive any applications as of now.
Yeah, so as we said, the course starts in September, so if you apply as soon as possible, really. We look forward to receiving your application. Okay, so I'll just wait to see if there are any more questions coming through. We'll just wait a few moments, but in the meantime, I think it's interesting to see at the start, our attendees all said 100% voted that they did not think that current health services were sufficiently person-centred. So I think it's been really interesting to pick that apart and see what that means and how that fits into the context of this course. So are there any kind of final words that you'd like to say, any almost advice or anything that you'd like to give to any prospective students that might be coming onto this course?
So come along, as I say, come along with your own ideas, be willing to listen to others and be willing to sort of understand people might have different perspectives to yourself, but not necessarily to be sort of in some simplistic way taught what to think about it, but to develop your own thinking and to develop your own position so that you are in a better case, as some of my previous students said, to defend your corner should you need to, and to be someone who is actually an instrument of progress, that you're making
Yeah.
changes in your areas, changes which, after all of sort of powers that be are saying we need to make. So it's not like you're being a terrible rebel by wanting to make these things.
No. And I mean, you know, it's our hope, really, our ambition, that the person-centered teaching here, or the teaching about person-centered care here, you know, will make you a person-centered clinician, and person-centered clinicians give patients a far better deal.
Yes, and you can, as I say, it's an area that's growing, and so you know, it's good to be there at the front of it, and to be someone who can say, yes, I know about this, I've studied this, and
Absolutely.
you know, there's a sense in which then you can be something of a leader
And,
in the area.
and to be an agent for change yourself in your home institution.
Yes.
You know, so hopefully person-centered care can be not only taught but caught, so you can actually be a mentor in your environment, and that's what we would certainly encourage you to do when you've completed the course and function in that way in the workplace. So it gives patients a far better deal than they're getting at the moment, for sure.
Sure.
Okay, brilliant. Andrew and Michael, thank you so much for your time. As I said, it's been a really interesting discussion. I hope you've all found it useful too. If you do have any questions following the webinar, you can email student.recruitment@uwl.ac.uk. If it's anything course specific, then we can forward that on to Andrew or Michael. He'll be able to help you and answer your questions further. So thank you very much for joining us today. We hope to see you soon.